Dr. Bob here, and still working through a lot of subject matter, just trying to cover the basic concepts of the various ailments that I would label as chronic disease so that you have a better understanding. And the next subject is the toughest one I'm going to cover. It's one that people are very sensitive about, and I guess a lot of times we probably don't consider it a disease, but it certainly has significant disease implications, and that's obesity. I got to start with, look, people are beautiful because they're made in the image of God, and it has nothing to do with their body composition. But I'm a little discouraged by what I'm seeing as a trend in social media and in general media and just sort of in the population that we're trying to say it's okay to be obese. And from the perspective of your own value and self-worth, yes, I agree. But obesity is not a cosmetic issue. Obesity is one of the biggest drivers of human suffering that we can look at. It's a tremendous problem in multiple domains. And so I'm going to talk to you a little bit about how obesity drives disease. I'm getting a little cart ahead of the horse because my plan was to cover the main drivers of disease after we define all the various components of chronic disease and discuss those basic entities. It's going to cover a lot of some of that I will discuss in much greater detail in the future. Okay, so obesity is the root cause of inflammation. It turns out that fat is inflammatory, and there's good scientific evidence that as you increase the amount of adipose or fat tissue that you carry, there's a linear effect on inflammatory markers that we can follow. And we will talk quite a bit about how inflammation drives disease, but for right now, I'm just going to make it simple. Inflammation is bad, and obesity is directly, linearly associated with inflammation. Now, all fat's not created equal, and there are genetic predispositions to where you store fat. And one of the things we can do in my clinic is we can determine exactly where that fat is through a DEXA scan. And we know that the metabolically dangerous fat is the visceral fat, the fat that is inside the abdominal cavity, the fat that surrounds your guts, your intestines, and your other internal organs in your coelom, which is the medical term. That is more dangerous than the fat that is outside the abdominal cavity, the subcutaneous fat that we carry, Now we speak about android fat, which is the fat around the waistline, and that includes the subcutaneous fat and the visceral fat. And we know that android fat, as it increases, is a risk marker. But visceral fat is a better surrogate marker for metabolic disease, and I have the capability of testing that. So obesity causes inflammation, and inflammation's bad. Inflammation is one of the key components of insulin insensitivity. Obesity drives insensitivity to insulin. It leads to type 2 diabetes, which we just covered in pretty good detail. So your risk of type 2 diabetes, given whatever your genetic parameters are, is going to continually increase as you gain weight that is not lean mass. There's a direct relationship between obesity and high blood pressure. Again, very linear and well documented in epidemiological studies. As people's weight increases, their blood pressure goes up. And it's pretty well established that for about every 10 pounds of excess fat that you carry, your systolic blood pressure will be about 5 millimeters of mercury higher. So obviously, there's a disease, hypertension, that many people, if they take themselves to their current weight, which is overweight or obese, and they drop down to an ideal weight, that disease process will go away. I've seen it demonstrated many times in patients that I've followed. There's gravitational effects, okay? Now, about the only benefit to obesity is usually people who are obese or overweight maintain a little more bone density, because that stress, that gravitational stress on the bones, will drive bone deposition and help maintain bone density, but at the expense of the joints. So though the skeletal system may benefit from increased bone density, the joints themselves will deteriorate much faster, and you're looking at debilitating conditions like chronic knee osteoarthritis and hip osteoarthritis, which will then lead to a marked decline in activity levels, a decline in the calories expended with the activities of daily living, and then we see a vicious cycle where the obesity worsens because we have less energy out. And we know that fitness is so closely linked to long-term health and well-being, reduced mortality, lower risk of cancer, and metabolic diseases. So it's obvious to see how this all feeds together. That being said, obesity drives cancer. Known, established fact. Multiple links. A lot of it's probably related to the other diseases it's driving, but it's created an inflammatory state. It tends to create a state where there's higher levels of sugar due to insulin insensitivity. And we know that inflammation drives cancer, and cancer feeds off of sugar. So obesity and cancer are linked. Rates of cancer are much higher in obesity. Breast is an excellent example. It's a major risk factor for developing breast cancer. COVID. If there's anything that we learned from COVID that is useful for long-term health and wellness, is that COVID made it obvious that obesity was more than just a cosmetic issue. Consistently throughout the pandemic, scientific studies revealed over and over again that whatever your other comorbidities were, your risk of a bad outcome, hospitalization, need for a ventilator, and death were all increased if you added obesity to the underlying conditions. So obesity was a driver for bad outcome. Now, it got so specific that I actually read, I want to say it was a Harvard medical study, where they actually looked at what was being deposited in the lungs in that cascade of damage that COVID was causing in these people that ended up with such severe symptoms, that they looked at the lungs of cadavers and determined that visceral fat molecules were being released because the virus was attacking the visceral fat, rupturing those fat cells. The fat cells were being released into the bloodstream, and it was directly responsible for the lung disease that was causing the severe oxygen deprivation, requiring these patients to be on high flow oxygen, ultimately sometimes having to be put on a ventilator, and sometimes the failure to be able to adequately oxygenate their system, even with mechanical ventilation, was such that they died a metabolic death. Let's summarize. So root cause of inflammation, which I promise you will understand in more great depth, is bad. It creates insulin insensitivity, meaning higher average blood sugars, increased glycation, which I'll explain in great detail in a near upcoming discussion, and increasing risks of other true diseases like hypertension, linear effect, cancer rates, increased rate, linear effect, significantly worse outcomes with metabolic diseases and things like COVID, which we saw obesity was a driver of bad outcomes, and then the skeletal system. Though it protects a little bit from frailty, it drives degenerative joint disease of the spine, the hips, and the knees in particular, leading to need for total joint replacements, which are always preceded by a period of decreased activity, resulting in worsening metabolic health. Is it a disease? Yes, it is. Is it markedly affected by lifestyle? Absolutely. Do we have excellent strategies for winning and beating obesity? Yes. Is it easy? Absolutely not. Is it possible and sustainable? Yes. Is it worth it? Absolutely. In the sense that it's a disease, there are genetic predispositions. When I get down to sharing my genome with you, I'll show you that I have a really significant obesity gene. It was one of my highest risks according to my genome. I obviously have figured out a solution to it. I maintain ideal body weight and have for 10 years now. There are multiple genes that drive obesity. It requires a combination of those genetics and a mixture of lifestyle issues to achieve the disease, to become obese. And some of those lifestyle issues can allow the disease to be undone, and that's the focus of health and wellness or preventative medicine, which we don't pay enough attention to. There are some sad parts about obesity. At a certain level of obesity, it becomes much more difficult to win the battle, so to speak. There are very complex things going on with our appetites and our motivation and drive to ingest additional food, sometimes beyond our energy needs and certainly well beyond our needs for nutrition. It turns out that at a certain level of obesity, demonstrated in both rat and human models, we become insensitive to the hormones that tell our brain that we should be satiated and full. There are ways that your gut talks to your brain. When you eat and you eat particular macronutrients and you have particular mechanical effects in the gut, hormone messengers are sent to the brain that tell you or your brain that you're satiated and should stop eating. And with extreme obesity, the sensitivity to those hormones is lost. So unfortunately, these people that reach that stage can't shut off hunger, which makes it a much more difficult problem to win against. But we do have strategies, from hormone manipulation to medications, that are really starting to look like an excellent avenue. And then sometimes just coaching, just teaching you what you need to know to understand what's going on, and strategies for basically, I spend a lot of time talking to my patients. I think recently I was seeing a patient in the office, strategies for energy stored equals energy in minus energy out. I speak with my patients often about the strategies for energy stored, which is the fat accumulation that we're making an effort to get rid of if it's in excess of our safety needs. I mean, there's a reason why we store some fat. It's to provide fuel at a time of famine, or we don't have access to calories. We have a way to go to our body and produce sugar by converting the fat back to sugar and releasing it into the bloodstream for use as energy. So we want to get to that energy stored, and we have to do that by making energy in less than energy out. And there are some great strategies just in lifestyle, how you eat, when you eat, and brief daily intense exercise regimens that can be utilized to alter this equation so we can start to get to energy stored. But there are medications that can help. Hormones can be beneficial. And all of these things will be covered in great detail on the how section. That will be what you guys are sitting through all this for, is to get to the how. And I promise I'll be as concise as possible, very clear and understandable. Hopefully you find my talks that we're using right now to cover chronic disease is filling all of those major bullet points that I just said. So I'm going to stick with it. I'm going to keep moving on. We have a few more subjects to discuss, and I want to get through all of that before I let the shade come down on the defining chronic disease and move on to the next step, which is the molecular drivers of chronic disease, where we'll talk about inflammation, glycation, small dense cholesterol particles as the drivers of vascular disease, and to a lesser extent, I wouldn't throw cholesterol in there, but definitely inflammation and glycation as drivers of cancer and other chronic diseases. So I'll be back with you guys shortly, and thanks for listening. Dr. Bob out. Remember, the more you learn, the more likely you are to expect success. Thanks.